Good afternoon and welcome to the IGFE seminar series presented to you by the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health. Today's webinar is co-hosted with the Blavatnik Institute from Harvard Medical School. I am Bene and I'll be your moderator for this talk. And today we're delighted to welcome Dr. Dale Barnhart and Dr. Todd Ruderman. Dr. Barnhart is an epidemiologist conducting postdoctoral research under the guidance of Dr. Bethany Head-Gauthier and Dr. Frederick Katira at the Harvard Medical School. She is also a research fellow with Partners in Health Rwanda. We're also pleased to have with us today Dr. Ruderman, who is a DO and is currently the non-communicable disease physician for Partners in Health in Malawi. Just a few standard logistics before we start. This seminar is being recorded, so please turn off your camera if you do not wish to be recorded. The recording will be available on YouTube and on our website at a later point in time. After approximately 45 minutes, we will stop for questions. Throughout the talk, you can send questions via the chat function to James Hay. You have the possibility to ask your question to our presenters directly. In that case, please notify James in the chat and we will ask you to turn on your camera and we will unmute you once we are ready to take your question. Back to our speakers. So Dr. Barnhart's research focuses on the application of epidemiological methods to implementation science and program evaluation. She completed her doctorate in epidemiology at the Harvard T.H. Chan School of Public Health in 2019. As a research fellow with Harvard Medical School and Partners in Health, she supports global health research capacity building in Rwanda under the mentorship of Bethany Head-Gauthier. In partnership with Partners in Health Rwanda and Inshuti Bizumu's Infectious Disease and Research Departments, she conducts and supports research on hepatitis B, hepatitis C, and HIV. She additionally serves as a technical advisor and founding member of the Partners in Health cross-site COVID-19 cohort research network, which helps to coordinate and facilitate COVID-related cohort studies across 8 participating sites. Our second speaker, Dr. Ruderman, is the non-communicable disease, or NCD, and mental health physician manager for Partners in Health in Malawi. He graduated from the University of Medicine and Dentistry of New Jersey, School of Osteopathic Medicine, which is now known as the Rowan School of Osteopathic Medicine. And he graduated in 2011. He completed residency in internal medicine at the Rowan School of Osteopathic Medicine in 2014. He has worked for Partners in Health in Malawi intermittently for the last 6 years. He has been the NCD and mental health manager for 3 years in Malawi. His clinical and research focuses in Malawi includes decentralization of type 1 diabetes and complex NCD services, evaluation and implementation of depression treatments, and supporting social assistance of NCD patients in Malawi. Our speakers will talk to us today about identifying vulnerabilities and supporting patients during COVID-19. Thank you very much for joining us, Dr. Barnhart and Dr. Ruderman. Please take it away.
Thank you so much for having us. I want to get started by acknowledging that the work that we're presenting today reflects a huge team effort, and it's work that has grown out of a longstanding partnership between the Division of Global Health Equity at Brigham and Women's Hospital, Partners in Health, and the Global Health Research Corps at Harvard Medical School. And this partnership is sometimes known as the Global Health Delivery Partnership. It brings together experts in clinical care, program implementation, and health research to try and improve the delivery of global health services. And because of this longstanding partnership, in March of 2020, when the COVID-19 pandemic was beginning, we were very well positioned to start a multidisciplinary cross-site collaboration among a large number of PIH-supported sites. And so this was a collaboration that was spearheaded by Dr. Jean-Claude Mugunga, who's the Deputy Chief Medical Officer at Partners in Health, and Dr. Megan Murray, who is the head of the Global Health Research Corps at Harvard Medical School. And they brought together clinicians, program implementers, and monitoring evaluation experts from 8 different PIH-supported sites, central coordinators from Partners in Health in Boston, and then researchers such as epidemiologists and biostatisticians from the Global Health Research Corps. And for me personally, I entered this collaboration kind of wearing two different hats. I am both an epidemiologist with the Harvard Medical School, but also through my fellowship, I've been living and working embedded at Partners in Health Rwanda. And so this was a really good opportunity for individuals with a wide variety of expertises and a wide variety of perspectives to come together and identify what are the research priorities for the sites in the context of this pandemic. What is the information that we need to know in order to improve the care for the patients? One of the things that quickly became apparent during our early conversations is that even though there were a wide variety of different contexts and different challenges that people were facing, there were some common goals. The first was to understand the burden of COVID-19 in the communities that we are supporting. But the second goal, and I think this is a goal that has become increasingly important as the pandemic has gone on, is understanding the impact of COVID-related disruptions on routine services. And so to address these common goals, we developed what I like to think of as a research menu. And this research menu is a list of different study designs. All of these study designs were developed in partnership with the sites that we are working with. But we think about it as a menu because just like a menu at a restaurant, our collaborators picked and chose the combination of research designs that made the most sense to them, given their research priorities and also their research capacity. And again, just like a menu item, we worked with the sites to customize it to make sure that the study designs that we were offering were really tailored to the research questions that were most important to our collaborators. So I'm not going to talk about all of these different study designs today. I'm going to focus on these four. And I'm going to spend the most time talking about the telephone cohort. I think this is a really great example where you can see how our collaboration between countries allowed us to improve the quality of research as we went on throughout this year. But to get started, I'm going to focus first on the syndromic surveillance work. And so this is work that has been led by my colleague, Dr. Isabel Fulcher, who is also a research fellow at Harvard Medical School. And the goal of syndromic surveillance was to try and assess the burden of COVID-19, even in settings where testing capacity was limited. And so the methodology that we used here was a time series analysis that relied on existing data systems that collect aggregate data at the health facility level. So in many of the sites that we work with, it's part of routine practice to each month report things like the number of outpatient cases that have acute respiratory infections. And so using this data, we were able to fit a model that kind of predicted what we would expect to see in terms of number and proportion of cases in the absence of COVID-19, and then compare what we would have predicted from our model, which is here shown in the gray, to what was actually observed during the early initial phases of the pandemic, which is here in the black. And so looking at these differences can help kind of identify spaces where COVID may be circulating, even if it's not possible to directly test for COVID-19 always. In addition to developing the statistical methodology, our team worked very hard on identifying ways to communicate the results effectively with our collaborators. And so different methods we used included things like a time series graph, which is what we showed on the previous slide, but also a heat map to try and track changes and deviations from what we would expect, both geographically and over time, and also more geographic focus maps to really be thinking about how this is changing in space. The second methodology I want to talk about is health service utilization, and this is a study design that uses very similar methods, again relying on that time series analysis of aggregate data reported at the health facility level. But instead of looking at an uptick in COVID-related symptoms, in this set of studies, we're looking at a reduction in routine health services. And so, for example, here you can see some work on a comparison of immunization rates. This is work that's being led by Drs. Emma Boley and Amelia Connolly in Liberia and Malawi, respectively. And so again, we're looking here to see, are the numbers of BCG vaccines being administered decreasing in the post-COVID periods? Similarly, we have work that is focusing on maternal and child health in this time, led by our colleagues Zeus Ramon in Mexico and Thierry Bendy in Sierra Leone. And I want to say, if this is work that catches your eye or something that you're interested in learning more about, we do have some resources available. We have a paper that's coming out in the International Journal of Epidemiology in the very near future, but also there is available code so you can reproduce these results, and also a video that goes into the methodology and the data visualization tools in a lot more depth than I can today. The third study design, and the design that I want to spend the most time focusing on, is the telephone cohort study. And so this was a study design that was really focused on addressing the concerns about chronic care patients. So all of the sites that we are working with have different populations of chronic care patients that come in regularly for services. And these chronic care patients could be patients with HIV, they could be patients with non-communicable diseases. But the idea is these are patients that have the potential to be vulnerable to COVID-19 for two reasons. First of all, they may be more susceptible to the direct impacts of a COVID-19 infection, but also, and really importantly, they are particularly vulnerable to disruptions in health service access due to COVID-19, or also disruptions in kind of access to like socioeconomic resources during COVID-19. So in many of the countries that we're working in, governments implemented very strong interventions to try and reduce COVID-19 transmission, and it was very effective at reducing transmission, but also had some side effects of impeding people's ability to, for example, go to health facilities or engage in economic activities. And so all of these factors combined had the potential to really impact the health and well-being of these chronic care patients. And we were interested in understanding a little bit more about what was going on with them. Of course, one of the challenges of collecting data during a pandemic is doing so in a way that is safe for both the patients and the data collectors. And so we knew we couldn't do in-depth data collection at the health facility. That would lead to congestion at the health facility and would not be safe. Similarly, we knew we couldn't do door-to-door data collection in a way that would be safe for the data collectors and the patients. And so what we proposed instead was to conduct telephone-based interviews that would allow us to ask the kinds of questions we wanted to ask while still maintaining safety. And the first country that implemented telephone-based data collection in their chronic care populations was Rwanda. They, in April and May of 2020, contacted over 200 patients from the HIV, NCD, oncology, mental health, and pediatric programs to assess how they were accessing care and kind of more generally how they were doing socioeconomically. And so some of our initial results from that survey have recently come out. We did see that a substantial proportion of patients were reporting at least one barrier to accessing healthcare. And this included things like not being able to access emergency care or medication, as well as skipping appointments or just general difficulties in getting to the health facility. Despite these barriers, we did see that a large proportion of patients were able to identify and use positive coping mechanisms to try and overcome these limitations and maintain continuity of care during the lockdown. And so these included some things like contacting their clinicians by phone or delegating family members to pick up medication that we considered as candidates to kind of incorporate into more routine care and make these kind of more systematic options that could be used to mitigate barriers to healthcare access during future crises. So, as I said, the telephone surveys are a great example of how this collaboration has allowed us to learn from site to site as we have progressed through the year. And so in Rwanda, the first takeaway from this study was that telephone-based data collection was feasible, even among rural patient populations. Initially, there was some concern that telephone coverage may be too low in these populations to have effective results, but this was demonstrated to be a feasible study design. One of the challenges that we faced in Rwanda was questionnaire design. So I think you can see here from the dates of the survey that data collection started very quickly after the COVID-19 was declared a pandemic, and very quickly after Rwanda went into lockdown. And because of that short turnaround time, there wasn't a lot of time to develop a robust questionnaire design. And so one of the things that we took away from that was that we kind of needed to have a strong tool on hand that could be readily adapted to new contexts in a way that was quick and speedy and really responsive to the needs of our colleagues. And so what we did was we developed a modular questionnaire. And here you can see our different modules that we offer. Some of them we felt like were essential and were things that we strongly recommended to anyone who wanted to implement this study design. But then we built in several options for expansion and several spaces where colleagues could pick and choose what are the things that they most want to prioritize in their telephone survey. And again, I think this just really gets back to some of the philosophy behind the research menu, wanting to be able to provide tools that are high quality and useful, but also being responsive to the actual needs and requests of our colleagues. A second advantage that I'm very excited about with this modular questionnaire design is we are hoping to be able to compare results and even potentially pull data across different countries that are using the same or similar questions. And so beginning in the summer of 2020, when Malawi decided that they wanted to implement a telephone survey in their advanced NCD population, we were able to use lessons from Rwanda to improve that study design. So we used that modular questionnaire and we programmed it into ComCare so that the team in Malawi could do electronic data collection. And initially we were planning to use this data primarily just to describe the situation among the advanced NCD patients, similar to how we were describing the situation among chronic care patients in Rwanda. But what we realized very quickly is that the timing of data collection was going to allow us to do a pretty interesting and effective evaluation of a cash transfer program that the team in Malawi was offering to advanced NCD patients to try and mitigate the effects of the lockdown. And so I'm going to turn this over to my colleague Todd Ruderman to talk a little bit about that specific program and some of our preliminary results.
Hi, thank you, Dale. My name's Todd Ruderman, and I'm going to talk a little bit more about the specific program that we did in Malawi. Just a real brief overview of the status of COVID in Malawi. There have been over 33,000 cases of COVID and just over 1,100 deaths since the pandemic started. There was a large spike in cases in January and February of this year, but that peak has since abated. Additionally, Malawi has given over 200,000 vaccines. Most of them arrived in March. So as Dale explained, in Malawi, and specifically in Ndeno district in Malawi, Partners in Health has a site that we've done a lot of work expanding non-communicable disease care. As a pilot district to expand non-communicable disease care in Malawi, we've been able to decentralize complex non-communicable disease care. So what that entails is that in Malawi, if you have type 1 diabetes, to get a high quality level of care, you need to be able to go to a central hospital in one of the 4 cities in Malawi. For over 80% of the people in Malawi that live in rural districts, that's impossible for them. So what we're working to accomplish is a way to provide access to high quality care for complex non-communicable diseases in a decentralized rural district. So some of the diseases that we look to treat and highlight include type 1 diabetes, sickle cell disease, rheumatic heart disease. Currently, our clinic treats over 350 patients with these advanced non-communicable diseases at our 2 hospitals in Menno District. And we have approximately 4,000 patients that we see at our integrated chronic care clinic, which treats more simpler NCDs, such as things like hypertension or type 2 non-insulin dependent diabetes. So when COVID hit, we were fortunate enough to receive funding from one of our from the Helmsley Charitable Trust, who is one of our primary donors, to provide cash transfers and social support for our patients in our advanced non-communicable disease clinic. What we decided to do was we wanted to make this a need-based cash transfer. So we did a baseline needs assessment in June and quickly developed a 10-question tool to try to assess patients in need for social support and their risk for food insecurity. We divided patients into 4 tiers, and based on what we deemed their level of need, they received approximately $40 per month at the highest need, about $20 a month at the tier 2, approximately $7 a month in tier 3, and no assistance in tier 4. It was more of a stepwise rollout because patients were enrolled as they visited the clinic, and not all of our patients were able to visit in the first month when we rolled out the cash transfer program. So as we see in our, so one of the things we wanted to look at was with this collaboration was this cash transfer program effective? And the timing really was really helpful because cash transfers occurred from July to December of 2020, and we did our first phone survey for our patients in December of 2020. So what this did was it was able to use the telephone survey data to have a timely real-world evaluation of the efficacy of these cash transfers to see if cash transfers really do help people with things like food insecurity and social support in a rural district in Malawi. And by having this baseline needs assessment and survey, we were able to adjust for socioeconomic status, which was able to shape the way we evaluated our data. So a timeline of the survey is here that in June of 2020, we did our baseline needs assessment. Funds were distributed July to December. For our telephone survey, we're going to do 4 phases every 3 months for a total of 4 times. We completed our first telephone survey in December, which is going to include the data that we'll talk about today. And we actually completed our second telephone survey a few weeks ago in March. And we're planning on doing an additional 2 telephone surveys throughout the rest of 2021. So our study population is as follows. We had approximately 350 patients, and of the patients that have phone numbers are approximately 177 that have access to phone. We had a pretty good response rate with about 82% of the people we were able to contact with the phone survey. Just a basic outline of the population is that about 2/3 of the patients were 40 years or older, which is a little bit on the older side of our overall patient population age. And we did have caregivers respond for patients that were minors. And additionally, again, these are many patients with severe chronic disease, and half of them had more than one chronic non-communicable disease. So looking at social vulnerability, we still found that there was pretty significant social vulnerability in the population. In terms of the household hunger score, just under 50% of patients said that they had moderate to severe hunger, and many patients expressed coping strategies such as selling assets, borrowing money from friends. Fortunately, we did not have we did not have significant barriers to medical care, which is something that we were proud of being able to continue doing in Menno during the pandemic. And most people said that they were doing better despite the pandemic, which I think was hopefully a sign of the success of the clinic in Menno. So what we did was we looked at some of the associations between the funding levels and social vulnerability. And despite having a somewhat small sample size, we're able to see that there was an association between the dollars awarded and the change in the vulnerability levels. Specifically in the highlighted areas, we see a small improvement in this data with considering the baseline socioeconomic status of these patients. And then if we look at the improvements per household member versus per patient, we see an even greater level of improvement. So what this did show was that the program did have some success with reducing food insecurity in our population. And then another thing we looked at was we used a model to predict the impact of the cash transfer program. And looking at the models, if we look at the chart on the left here, the gray bar shows what we would expect without cash transfers in terms of the percent of people that would say that they were worried about food, worried about their self-reported health, how many needed to sell assets, and any financial coping strategies. And what this, and the orange bar shows that the cash transfer, how that was changed. So what it shows was that for some things like being worried about food and financial coping strategies, using, the cash transfer program flattens the risk of some of these social vulnerabilities despite baseline socioeconomic status. So again, we see that there was good improvement with the cash transfer program. Another thing to point out, though, is that there still is a pretty significant amount of vulnerability in the population, and that even despite this, over half the population reported, the model shows that over half the population worried about food, and many still needed to do different financial coping strategies. So some key points of this is that despite our small sample size, we did see that funding was associated with some significant improvement in some of these key indicators. But we do realize and recognize that there's a long way to go before we really significantly reduce these vulnerabilities, and that a big part of that is receiving more funding to do additional cash transfer programs or different food distribution. Associations were stronger when we looked at dollars awarded per household member, which reflected the importance of the household level vulnerability. And we're really hoping that this is, almost a start to some future economic different evaluations of economic interventions for our patients in Nano District.
Thank you, Todd. That was a great summary of our work. I want to continue to kind of build off of this, the telephone survey, to kind of show some of the future work that we're doing, and just to highlight the fact that our cross-site learning is continuing as these projects progress. So in Malawi, again, we have the opportunity to continue this work through some of our future rounds of survey collection, and we do plan to kind of track to see how things are changing over time in these patient populations, and ultimately link the survey questionnaire data to some of the clinical outcomes for the patients and assess those associations as well. But in addition to ongoing work in Malawi, this work in Malawi was able to inform some future work in Sierra Leone. So after seeing some of these initial results, the team in Sierra Leone reached out and said that they were also interested in doing this sort of telephone survey among their non-communicable disease patients. And so we were able to use our experience in Malawi in two ways. The first was that we adapted the existing ComCare questionnaire to support the team in Sierra Leone. And I think that highlights one of the great opportunities about working together in a collaboration like this. We have really been able to reduce a lot of the duplicative efforts by taking some of the resources and some of the work that maybe went into the protocols, the questionnaires, the programming in one location, and move it forward and share that work with other team members in a way that has allowed us to do more research together than we ever could have individually or siloed. The other thing that we were able to take from the experience in Malawi is that recognizing that we could use this telephone survey as a way to evaluate some of the programs that were put into place to mitigate the effects of the pandemic. So again, in Malawi, we didn't necessarily plan to do this evaluation, looking at the association between the amount of money provided through the cash transfer program and patient outcomes. But when we realized that we were able to kind of pursue that research question, that was something that was of great interest to our team in Sierra Leone. And in that group, they did not do a cash transfer program, but instead they did a food assistance package. And so knowing that, we were able to build some additional questions into their questionnaire to help us, more proactively build that evaluation into their survey. So the final study design I want to talk about today is the historic control cohort. And this is something that I'm really excited about, but it's definitely looking forward towards the next steps of our collaboration. And the historic control cohort, I think, is a really fabulous opportunity with this particular team, because Partners in Health has a really long history of using electronic medical records for their chronic care patients. And so these electronic medical records have previously been used for both improving quality of care, but also for assessing the implementation and evaluating some of the clinical programs. And there has been a substantial amount of research done using the electronic medical data in individual sites. But what has not been done before is taking data from multiple sites and pulling it together and kind of comparing and contrasting and seeing how different programs are doing. And there's a lot of strong potential in conducting this kind of pooled analysis, because as you can see, there's a lot of innovative programs that are happening at the different supported sites, but they're not always implementing the same program at the same time. Additionally, just in terms of this as an incredibly rich resource, there are just a large number of patients that have been followed for many, many years in these data sources. And so it is an incredibly rich resource to be conducting some of these analyses in. For example, if you're thinking about HIV patients, when you combine the 4 sites that have electronic medical records for these patients, you're talking about a group of over 30,000 patients. And so what we are hoping to do is use these data sources to conduct a retrospective cohort study where we will compare outcomes among patient populations before and after COVID-19. So again, just looking to see, using the pre-COVID periods to kind of establish a baseline, and then looking to see how have patient outcomes been disrupted during the pandemic. And we're looking at a series of key outcomes, including service utilization, service provision, and clinical outcomes. And I want to give a little bit of background for where and how we think that these kinds of outcomes might be affected. Obviously, the overall national context, including policies like lockdowns, can have a major impact on patients' abilities to access care. But also there's factors like the regional COVID-19 prevalence, which has varied quite a bit in the different contexts that we're working in. And these kind of national and regional contextual factors can influence patients by increasing their fear of COVID-19 and perhaps encouraging them to stay home rather than coming in to access health services. It also can impact their ability to get transport. So I think we saw in the survey results from Rwanda that lack of transport was a major difficulty and a major barrier for some of those patients accessing their regular health care. And so we think that these are the kinds of factors that are going to play into a reduction in service utilization. At the same time, we know that there's been meaningful changes in service provision. And these changes can come from a variety of different places. They can come from reallocation of some of the resources from routine services to the COVID-19 response. But also, and increasingly, I think that there's an appreciation in our team that a number of intentional programmatic adaptations were made early in the pandemic with the hope of perhaps reducing the number of times patients would need to come into the clinic, but still making sure that patients could have access to high quality care. So these might be things like making a multi-month prescription, right? It's in some ways going to reduce service provision. You're having fewer appointments, but at the same time, you're having fewer appointments in response to this intentional adaptation to the clinical program. And so we think that, you know, these two factors are ultimately going to have an impact on the patient outcomes, including things like death and loss to follow-up. But one of the things that I am most excited as we pursue this work going forward is not just to be documenting kind of the magnitude of the impact of the patients. We do think that there have been, you know, some meaningful reductions in service utilization and service provision that could impact clinical outcomes for at least some patients in some clinical programs. But I also think it's important and really interesting to try and identify the clinical programs and the geographic areas where these clinical outcomes did not worsen. So again, speaking to maybe some of the strengths of these intentional programmatic adaptations, were there spaces and clinical programs where, despite the pandemic, we saw strong continuity of care and we saw consistent patient outcomes over time? And what can we learn from those settings? So I want to end here by acknowledging that this is a large team effort. We have an incredible team, and I think it has just been a tremendous privilege to be working with these individuals who have been really committed to meaningful collaborations and to this research work, even in a time when many of them are also facing additional clinical burdens. And it's just been a really wonderful experience to be working with this team. With that, I'm going to thank you and also thank our funders. Todd and my contact information is up here. And if there are any questions, I'm happy to take them now.
Thank you very much for this terrific talk, Dr. Barnhart and Dr. Ruderman. We do have a few questions, and we'll try our best to accommodate as many questions as we can. Remember that you are allowed to submit your questions to James via the chat function. So the first question we have is from Don Goldman, sorry. And so he's asking if, is it feasible and planned to scale up the cash transfer program and or adapt it for other contexts and needs?
Todd, do you want to, because I know that there are some plans for similar programs in the future, do you want to talk about that a little bit?
Yeah, no, that's a really great question. The simple issue with cash transfer programs is that they're expensive. I mean, that's the simple issue. And, you know, it's really difficult to provide a quality social assistance and helping prevent food insecurity in a cost-effective way. I guess so that's, I mean, the short answer. I mean, the other thing is that in NENO, we are trying to be more creative with other programs. We have a plan to do a program to improve farming techniques, to build greenhouses to help provide our patients with quality fruits and vegetables while also teaching them improved farming techniques and providing them a side business to help with funds. So we're looking at different economic development programs beyond just basic cash transfers as well. So it's a great question. There's a lot of interesting options and something we're really trying to investigate for the future. So thank you for that question.
Yeah, thanks for the reply. I asked because the evidence is getting stronger and stronger on cash transfers, even those that are not specifically purposed. And some of the programs you mentioned, especially around indigenous agriculture, really potent forces for change. but I haven't seen a lot of embedding it into the financial realities and the policy decisions of the regions and countries in which they've shown such promise. So that was why I asked.
Yeah, thank you. And we're hoping that as we continue to work with the National Ministries of Health, we can help the work we're doing guide it for Malawi and kind of helping move the conversation that way and realize, not just that it's that providing social assistance is almost necessary for medical care. In patients with type 1 diabetes, we can't give them insulin if they don't have food to eat. So we're really trying to move that conversation towards that idea. So thank you so much.
Thanks.
Thank you, Dan, and thank you, Dr. Ruderman, for answering. I have a question that is more for you, Dale, regarding the telephone-based data collection system that you talked about. I was wondering, actually, in a similar way than Don Goldman, if you think this could be put in place in countries in the longer term to guide disease intervention or educate people on specific aspects of diseases or improve or maintain access to the healthcare system by collecting data. I know this has been critical for China, for example, when they started their 137 malaria response. And so I wanted to have your opinion on this, and also if you could provide any pieces of advice that you think could be useful to implement this.
Yeah, I think that that's a great question. First of all, I do think that telephones can be a really useful way to conduct research, but also just to have outreach with the patients. For example, in our Rwanda survey, we did see that patients kind of independently contacting their clinicians with a telephone was one of the ways that they were able to kind of overcome some of their barriers to accessing healthcare. I do think the extent to which you can rely on telephones depends on a few different things. First of all, thinking about questions like telephone coverage and also service. It was a really, very sincerely a big question at the beginning of this project, whether telephone surveys would even be feasible in the context that we were working in, because we were concerned that not enough patients would have phones and not enough patients would respond for it to be a useful and insightful program. We did see that even kind of comparing Rwanda and Malawi, there were substantial differences in the rate of telephone coverage that probably reflects a couple of things. First of all, it seemed as though telephone numbers were not being systematically updated and collected in the electronic medical record system. So I think that that was kind of an important implementation factor for us to be aware of, that, if you want to be able to use phones to contact patients, you do need to be kind of updating that information regularly, particularly in the settings where we work, where patients are often changing phone numbers quite frequently. The other thing that Todd didn't mention, but is I think important to think about in the context of the advanced NCD clinics in Malawi, is that there was an effort to provide some of those patients with telephones at the beginning of the COVID pandemic, again, to try and give them an alternative manner of contacting their clinician, even if they couldn't physically get to the clinic. And so that kind of phone provision was one of the reasons why the team felt like telephone surveys would be an appropriate data collection tool, specifically in the advanced NCD patient population. So I do think it is a tool that can be used and can be used successfully. I also think you have to be quite intentional if you really want to be incorporating it into some of your clinical programs.
All right, thank you for that answer. And another question that came up is, do you think, either diplomatically speaking or via partnerships with the private sector, it would be, some interventions would be made easier via, the making equipments more available or improving some of the data management systems in a way to help manage this kind of data or help reaching out to people more easily?
Could you be more specific about what this kind of data is? Perhaps the question is not fully specific on it.
Yeah, no, the question is not this specific, but any kind of partnership that you think could have been useful in the work you've been doing so far.
I will say, you know, there are some real challenges to doing this kind of collaborative research, and certainly data sharing and considerations around safe and ethical data sharing has been a major consideration and something we've spent a lot of time on. I guess a few thoughts on that. That is not an area in which I have a ton of formal training. And I do have to say, I've really appreciated some of the feedback from our collaborators from sites who I think have perhaps learned from sometimes bad experiences with data sharing, what kinds of policies and practices need to be in place for these kinds of collaborations to be successful and respectful. So certainly over the course of this year, I've had to have a lot of conversations about what are the practices that we can put in place that make data sharing feel comfortable and that make this kind of research really truly collaborative. In particular, lots of feedback from our colleagues in Sierra Leone that was incredibly helpful. And I think that even though it is very time consuming and can be very difficult, those are really important conversations to have early on. And I do hope that as we are continuing to collaborate together on this body of COVID related research, these kinds of conversations and these kinds of relationships and these kinds of systems that were being put in place now can be used to help create new opportunities to collaborate, not just focusing on COVID, but focusing on some of the other shared research questions among these different teams.
All right, thank you for your answer. We have another question that came up. So you talked very briefly about the syndromic surveillance research. Could you talk more about how that was used to inform decision-making or understanding of the pandemic in the locations it was used?
Yeah, so I think one of the, let me just go back here for a minute. No. One of the countries in which we had, I think, the earliest and one of the countries that had the earliest uptake on this research was Liberia, and our team in Liberia also was able to use this methodology, not just to look at the uptick in acute respiratory infections and other kind of COVID-related syndromes in PIH-supported sites, but nationwide. So if this is something that you're interested in, I think that there are some specific examples in this upcoming paper to talk a little bit about what they found and how they were able to share and disseminate that information. I do think that one of the things that has been exciting coming out of this work is that as we have been developing better tools for communicating these results, there's increased interest in using these methods, and especially the health service utilization methods, to kind of do more ongoing monitoring of some of these routine service provisions. And so again, thinking outside of just like the COVID time period, can we be using these kind of to proactively be ready to kind of monitor reductions in service provision in other time periods for other crises or for other reasons to improve quality of care?
Great, thank you for your answer, Dr. Barnhart. Another question that just came up, to what extent might your findings and methods be applied to other low and middle income countries, and what other considerations might you need to account for?
So I think that there has been quite a lot of variability in how the countries we have worked with have experienced the COVID-19 pandemic. I think that a lot of these methods are very broadly generalizable. And I do think that some of the experiences of patients, especially thinking about how the COVID-19 pandemic in many of the countries we have been working in has perhaps had a larger impact on some of these kind of indirect health, has had kind of a larger impact on health for some of these patients in an indirect way, right? By disrupting these services, by disrupting access to care, because for many of the countries, the pandemic has been relatively well controlled and certainly better controlled than was anticipated at the beginning of the year. So I think some of those results are more broadly generalizable. I am really interested and excited, again, to be thinking towards the historic control cohorts, where we will be kind of more explicitly comparing kind of the same outcomes across different countries and in different settings, and may be able to kind of tease out any like important differences that are perhaps geographic or perhaps related to contextual factors, and think about and talk about that in more detail.
All right, thank you for your answer, Dr. Barnhart. I think we went through all the questions that we had queued, so I think we can stop there. On behalf of the Center for Communicable Disease Dynamics and the Harvard Chi Chan School of Public Health, I would like to thank Dr. Barnhart and Dr. Ruderman for joining us today and for their talk, as well as the insightful answers they provided to the questions we asked. Thank you as well to everyone in the audience for your engagement and your questions. And please do get in touch with any of the seminar organizers if you have questions for us or for our presenters. Please check out the CCDD website to stay up to date on upcoming seminars and other events. Thank you again for joining, and enjoy the rest of your day.